Yeah, thanks everyone for coming along, and thanks to Nicole and the team for having me. This is really exciting. So yeah, thanks for the lovely introduction. As I said, my name's Alex. I'm an exercise physiologist with the team at Up and Active Physiotherapy and Exercise Physiology. So I met up with Nicole a few months ago now. We've been in the process of trying to get the ball rolling with this for a while. And she was her and the team were telling me that, yeah, common pain, discomfort, things that, we all sort of see and unfortunately experience to be the knee and the low back, and pretty well maps up with what I do a lot of work with at work as well. So yeah, great opportunity to present a little bit of information, get a bit of information, and please ask as many questions as you like. So what I've set up today, I've tried to make it as simple as possible without making it too clinical or university-like, as to say. But if you want more information, please yell out. I'm happy for questions and discussions throughout. So as we said, knee and low back pain. Just to get a bit of a gauge, how many people at any time in their life have had some sort of bout or experience of some sort of knee or back pain? Yeah, I think everybody, myself included. So yeah, great topic to sort of cover. So my goal, I managed to mess up the two buttons. What have I done there? I think I just pressed down.
I would have done the same too.
Yeah. So my goal today, first thing, what I want to cover is understanding a bit of the background behind pain. Pain is one of the most complicated things ever that the medical and research community, while they might pretend that we're all over it, there's still so much more and more to learn. But to give us a bit of a background on where the research is at, look at a few different common pathologies around the knee and the back and what can potentially cause them, what we can do about them. Go through a few gym myths, I suppose. There's a lot of, I'm sure these guys are all on top of it. If anybody's heard of any of the, don't lift like this or that, a couple of myths, we'll cover all that and how it affects the knee and the back. Things we can implement in the gym and what you can chat about with your trainers to try change around for your knee and back. And then when is it the point that we should go, yeah, you know what, I need to chat to somebody about what's going on here. So yeah, straight into understanding pain. Now, obviously, quality is not too great. This is a bit of a mapped chart of all the things that contribute to pain and how we interpret pain. And this is, as everybody's sort of looking at, it's ridiculous. There is so much going on here. I don't want anybody to get too caught up in that. Thank you. We try our best not to get caught up in it as well, because it's incredibly complicated. So the approach to pain that we actually use, let's see if I don't mess it up this time, perfect, is what we call the biopsychosocial approach to pain. So trying to understand pain, this is what we use these days. 20 odd years ago, everybody just thought biological stuff, is there tissue damage, what's happened inside the body, without thinking too much about what psychological impacts are happening and what social impacts are happening as well. So biological, pretty straightforward: tissue damage, muscle tears, fractures, neurological things, all of that. We all know that exists and it happens. But what else impacts that? Obviously psychological stuff. What are our beliefs and fears around pain? What are our expectations? What's our history with that sort of pain and injury? All right, there's a lot more going on with that too. And then social stuff. This one is probably the most confusing, but the people that have a really good support network or social network, and I look at a facility like this and go, yeah, you guys have got a great group and team network. It might sound silly, but the people that have that network tend to tolerate and get through pain a bit better than the people that are a bit more isolated. So yeah, this is something that not a lot of people consider. And the example I sort of use here is, if you think about a time in your life you've been really stressed, you might have uni exams coming up, or you're going through something traumatic like a family member passing away. Something small like stubbing your toe on the corner of a piece of furniture probably actually hurts a hell of a lot more during that period than it does when you're feeling really good. And so we sort of think about, put that into context of somebody that lives in a nice, lovely place like Toowoomba versus somebody that has no resources, facilities, staff, experts around the place in rural Queensland. The research actually says we get better pain outcomes living somewhere like this than we do out whoop whoop. So pain is complicated. Okay, that's the message I want everybody to take from this part at least. So in saying that, I've got a few points up here. It might be hard to see, but pain does not necessarily always equal damage. All right, pain is a signal from the brain Our brain's number one job is to stay alive. That's all it wants to do. So it'll send a message to say, oh crap, please don't do that. I want to be protected. Or it might be oversensitized for whatever of these reasons. And pain can just be a message of nothing's actually wrong, but hey, wasn't a fan. All right. We've already sort of covered this. Pain is very complex and multifactorial. There's a billion things that contribute to pain, and everybody's going to be very, very different. What works for one's not going to work for the next. And like I sort of just touched on, pain is very much a protective mechanism. There isn't necessarily always damage. It can just be the brain going, not a fan, don't do that again. All right. So I used the example just earlier of think of a time when you were really stressed or going through something traumatic, and pain's typically a little bit worse. The other example I like to use is we probably all know somebody that's always a little bit...
Just need to talk a little bit louder for people in the back. For the people in the
Oh,
back. Just talk louder.
of course, can do. Sorry, everyone. The other example I like to use is most people know somebody that is kind of always a bit negative, a bit down, the world's against me, things like that. That person tends to always have the, oh, I'm in pain, my back hurts, my knees hurt, my hips hurt, I can't do this. So that sort of touches a little bit on the psychological and social components here of when we have the right support, we have good mental health, we're looking after our body, we're eating well, we're sleeping well, we're doing all the other things. It's not just the tissue damage that affects what we feel, it's psychological and social as well. Don't get me wrong, I'm not trying to take away from tissue damage, it bloody hurts, but there's more things to consider. All right. Does anybody have any questions on that? Because that's, you're right. That is really complicated, and I don't want us to focus too much on it. We're here for knees and backs, but any questions?
No, but it's definitely an eye-opener. Like, you know, it's just, you don't think of it like that, but it all doesn't make sense. It all just comes together.
Yeah, and it's really good to recognise, and I'd be lying if I said anybody understood it quite well. I think we're all a bit like, it makes sense,
Yeah.
but nobody's perfectly all over this. And
No.
if you're ever at the doctor and you're like, oh, my back hurts, and the doctor goes, well, how are you sleeping? It might sound irrelevant, but there's so much more than just the pain. So that's why those questions are asked. So moving next, a big injury contributor, particularly if you're in the gym or just trying to get into a bit more physical activity, is load versus capacity. And this is something that the trainers here are probably on top of, but I'd like to get everybody as educated on this as possible because it's going to make my job a hell of a lot easier as well if everyone's all over it. So load is basically what are you asking of your body, and then capacity is what is your body happy to work with. All right. And the examples I've thrown up here, you probably can't see it too well, but let's say your body has the capacity to tolerate 3 kilometers worth of jogging, or if you're going to run club tomorrow and you're doing the 2.5K walk, but you say, you know what, I'm going to push myself, I'm going to try run the 5K. It might be that your body's happy to tolerate this, that's your capacity, but you're asking this as a load. You probably won't necessarily injure yourself if you try that, but there might be that message sent from the brain to go, hang on, I only wanted this and you're asking this of me. And again, we may not probably don't actually have any sort of injury, but you're probably going to wake up the next day and go, I didn't like that. So load management is one of the key things that I will be chatting about today. So examples of where common load management errors occur is returning to sport or training too soon after injury. If you've hurt yourself and you come back way too quickly, you're not going to have the tolerance to do what you used to be doing before injury. All right, pretty simple, but you'd be surprised how many people come in and see me and I explain that and they go, oh, makes sense. Limited recovery. So I've already harped on a little bit about sleep. We need sleep. We need to be eating well. We need to give ourselves time to recover. And then the last one, which again, we've touched on a bit, is asking too much of your body. You can't run 10K every day. I mean, some people can. Most of us probably cannot. I cannot. Okay, so really easy equation to try to figure out. If your load is higher than your body's capacity, there's probably going to be some sort of pain or discomfort. If your capacity is higher than your load, that's where we create adaptability. That's where the brain changes, the body changes, muscles changes, grow and adapt. Okay, so finding that capacity and your load is a really tricky part. It's a little bit of trial and error, but we'll cover a little bit more of that later on. So let's go into knees. Out of everybody who's had some sort of knee injury, has anybody actually got I had exactly this happen, or it's just I've had a bit of pain? Does anybody have good examples of something that they've actually had diagnosed going on? Yeah?
When I was 19, I ruptured my ACL ligament
out. Things in my bone and my TTF ligament is still on. The rest is fixed and still. Screws in it holding it.
Excellent example. That is. I wish people I worked with gave me that sort of a history, actually. That's really good. Yeah, so really good example of one of the things of one of the major knee injuries that we can have and obviously give us a bit of pain. What I've sort of got listed up here is a bit more of your general ones that most of us are more likely to experience while we're in the gym or just physically active. The first one I've written is patellofemoral pain. Sounds fancy, sounds funky. It's kind of, patellofemoral pain is a bit of an umbrella term to say pain in the knee joint. We're not necessarily certain on why. So obviously ruptured ACL, cartilage damage, we can go bang, bang, bang. That's why you're in pain. Patellofemoral pain becomes a bit more, you're in pain. There might be some deficits here, or you've had this injury previously, but it's just a bit of an umbrella term. Tendinopathy is another one. Everybody's probably heard of tendinitis, tendinosis, tendinopathy. Tendons, so we've got muscle connects to tendons connect to bone. Muscle pulls on tendon, moves bone, we get movement. Tendinopathy is basically a grumpy tendon. And the most common one, which a lot of people have probably experienced without necessarily knowing what it is one called jumper's knee. Jumper's knee is where we get pain right on the front of our knee. There's a tendon from the kneecap down to the front of our shin up here. That fleshy part of the middle is your patellar tendon. It's basically that guy. Going back to load and capacity, that tendon going, woo, you're asking a bit too much of me. And it can tolerate it for a little bit, and then one day you wake up and it goes, nah, not anymore. Yep, super common. And so it's kind of, if you don't give your body the rest and recovery and the load that it needs, it will force you into that by saying, ding, 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 here's the alarm bells, we're in pain. And then the third one, again, very umbrella term. I've just written down training load errors. Training load errors sort of accompany tendinopathy and patellofemoral pain and say, all right, well, we've done too much, or our body wasn't ready, or we weren't well enough recovered, or we've come back too soon. That's how we actually get these ones. So most of our knee injuries and back injuries as well do come from training load errors, except the ones that are a bit more traumatic, like a ACL rupture and meniscal tears and things like that. They can be training load errors as well. If we're not recovered, if we're not fit, if we're not strong, we are more likely to experience those injuries. If you look on the footy field, that someone gets tackled, their foot gets implanted on the ground, the knee twists and buckles in. You know, maybe if they slept a little bit better, maybe if they're a bit stronger, they resist that on that day. It's really hard to say, but all of these things contribute to developing pain injuries. So yeah, rapid load increases. We don't go from squatting 50 kilos one week to 100 kilos next week. Kind of common sense, but you'd be surprised. Poor recovery. Again, I'm going to say the term sleep a lot. We need sleep, we need food, we need protein. Technique. I'm sure you guys are in very good hands here in terms of exercise technique and how you're doing things. And deconditioning as well. If you get a little bit crook or ill and you decide, yeah, I was squatting 50 kilos a month ago when I was in the gym and I've been away for a month because I've been sick, that's fine, let's go squat 50 kilos again. There's that training load error. Our capacity gradually goes down and we're asking this much of it. So I've said training load error a lot. If everybody can walk away and be like, that's right, load capacity, you've got the message from today pretty well. Now, yeah, right. What, has anybody heard, there's a bit of a just yell out here. Has anybody heard or read of, oh, don't do this exercise because it's bad for your knees? Yeah. Any exercises in particular? What's that? Lunges, yep. Running, yep. There's a few that you'll hear and read, and yeah, lunges and running and, well, yeah, they're probably the big two. I'm very firm on the opinion that there's no such thing as a bad exercise. It's how we approach the exercise. And again, training load, error, load versus capacity. Okay, so yeah, like I said, squats, lunges, running and stairs are often cop a bit of a bad rap. Like I sort of touched on earlier, if we're deconditioned or if we're injured and you've got a bit of that patellofemoral pain and you go, yeah, you know what? I'm going to try these lunges. Chances are you're going to be in a bit of pain. And most people go, oh, those lunges put me in pain. Therefore, lunges equal bad. Not necessarily. It might be the range of motion, it might be the technique, it might be the type of lunge, it might be the block you did it on, it might be what time of day you did it, it might be how you slept. Sounds silly, but yeah, again, my big thing, no such thing as a bad exercise. It's just how we approach it or modify it, okay? So with a lunge, for example, lunges they're a hard exercise, but if we reduce the range of motion from trying to get our knee all the way to the ground to just getting it halfway to the ground, you're still lunging, we're still getting some unilateral quad and glute work, we're just making it tolerable for what your body's happy to actually work with, all right? So one of the big questions as well is when we're in pain, and I think for this group who seem really motivated and keen, is can I still train while I've got this knee pain? And unfortunately the answer is it depends, but hopefully I can give you also a bit of a guide to walk away with today to go, all right, should I go to the gym tomorrow? Should I go for a run tomorrow? Should I not? Okay, ultimately the answer is going to be, we can probably modify it to make it appropriate. But I've got a few questions up here you can ask yourself. Nicole's got a copy of these slides, so you can, I'm sure she'll hand them out afterwards. Please read through and ask yourself the questions if you ever need to. First one is, what was the mechanism of injury? So mechanism as in, was there an event, okay, that actually caused this? Number one event I see at work is sporting injuries, rolled an ankle, twisted in the ground. And then secondary, a little bit more with the older population that I work with, is falls, tripping over and knocking yourself on the ground. If the injury comes from some sort of a traumatic event, like a fall, we trip over, smash the knee on the ground, chances are if we're in pain after a traumatic event, it probably needs to be checked out just in case there's something a bit more sinister going on, like a fracture, okay? But if the mechanism of injury is, oh, my knee was a bit grumpy yesterday, but it's okay today, and then I trained and it got worse, and then the next day it was worse and worse and worse, and it just builds up over a period of time, we're probably actually okay to train, but if we modify it, okay? And we will cover more of that. Signs of inflammation, so your typical ones of, are we swollen, red, hot, tender to touch, things like that. We're allowed a bit of inflammation. Inflammation, generally speaking, is the body trying to heal itself. We send white blood cells to the sore part, to the injured part to try recover. So inflammation's allowed, but again, think about the mechanism of injury. If you've had a fall or been in a car crash and your knee's this big and red hot and leaking ooze and yucky stuff, maybe not, okay? This might sound like common sense, but again, you'd be very surprised. Full range of movement. So a knee is a very easy example. It's a pretty simple joint. It goes forward, it goes back, all right? If we go, ow, I can't get any further straight, that really hurts, we probably can't actually lunge or squat that day. Maybe not, maybe we need to get it checked out. The big one is probably weight bearing. Again, depending on the trauma or lack of trauma, a really easy test you can do at home. And this isn't just the knee, this is the ankle and the hip as well. If you can try stand on one leg and go, yeah, that feels okay, you're probably okay. All right, I want to emphasize probably, and then I'm talking very generally here. Whereas if you try to stand on one leg and you go, oh, geez, that doesn't feel good, there's probably something a bit more sinister going on. Let's get it checked out. Let's have a bit of a rest and avoid training. And then specific pain patterns or aggravators. What I mean by this is, and it's the most common example, waking up in the morning going, oh, gee, my knee is stiff and sore. You get out of bed, you have a shower, you go about your day, and it gets better. What's going on there probably isn't too sinister. Again, we modify, reduce load, and we can get through a few different things. Versus the pattern of you wake up in the morning and you go, oh, a bit stiff and sore, and as the day goes on, it gets worse and worse and worse and worse, and it doesn't get better until you go to bed again that night. Let's get it looked at. All right. Does that make sense to everybody? Yeah, awesome. Because again, what I want to iterate with this is exercising 99 out of 100 times is always good, always safe, if we load it and modify it appropriately, okay? So when training may not be the best, massive traumatic injuries, very inflamed, significantly reduced range and inability to weight bear. We go over a few more later on, but the other thing is use your common sense. If you're there going, this doesn't feel right, I don't feel comfortable with this, don't try train. Let's get it looked at, okay? Any questions there? It's very generalized and I apologize about that, but like we said, yeah.
Say I've got, a bit of a lower back pain on my right hand side here.
Yep.
But like I said, well, I was actually playing a game with Mia last night, and I can stand on one leg just fine.
Yep, good, good.
But then, like, say with lessening the load, like with Joe the other day, it's like I went back on my load because I was taking it took the pressure off my lower back.
Perfect example.
So that
Yeah.
it does all make sense.
Yep, that's it. The general rule, and we go over it more again later. If it makes pain worse, don't. If it doesn't change pain or makes pain better, do. Okay, sounds simple, but perfect example. If you come in and, like I heard this morning, 3 minutes of burpees.
Yeah.
Yeah, no, yeah, I feel sorry for you that did that. And if you come in and go, oh, Nicole, my back's killing me today, maybe it's 2 minutes of burpees. All right. Yeah, maybe it's none. Yeah. Depends how she's half burpees. Yeah.
I might negotiate with you.
Yeah. And that is actually the perfect example of modifying these exercises to go, all right, a full burpee is going to be too much. We do a half burpee. All right. Okay, so actually that segues into this perfectly, exercise modifications. And this is something that your team's going to be all over, but it's really good if you guys can get a bit of an insight and go, all right, maybe today I do this, or when I go for my walk tomorrow, I change this. So group-based activity now, yell out some answers. Coming in and doing your barbell or goblet squats, or dumbbell squats, kettlebell squats, however you're doing them. If your knees or back's a bit sore today, what do we think we can modify a squat to? And there's not really any wrong answers here because it's going to be different for everybody.
Don't use the heavy one.
Perfect. Really simple one. Make the weight a bit lighter. Any particular other exercises anyone can think of?
Knee movements.
Yeah, yep, knee movements. It might be that simple of going, all right, instead of squatting today, let's still get the legs working. We're doing some sort of a marching activity or something like that. The easy examples that I will often implement is, all right, well, a regular squat hurts too much. Maybe we do a box squat or a sit to stand. So let's put the chair behind us and sit down to that, come back up. Makes it a lot easier. You don't have to absorb as much impact. It slows the movement down a bit. And maybe, like, these aren't permanent changes. It's just something we do once or twice, or for a week or two. We're back into your regular squats. Deadlifts are the next one that I think a lot of people go, oh, I better just avoid these, I'm in pain. Not necessarily wrong, but what do we think about does anybody have any ideas on how we modify a deadlift?
Potentially rather than doing barbells, like dumbbells, single leg, or some kind of
Yeah,
single thing.
perfect. Yep. Again, there's not really a wrong answer here. If a regular conventional deadlift hurts or is uncomfortable, maybe we do go to a bit more of a dumbbell where we have, less load. We can go a little bit less range of motion on there. Alternatives, from a conventional deadlift where we've got our knees a bit more bent and hips still up, but a bit more bent. If the knees are a bit grumpy, maybe we look at a Romanian deadlift where our hips are up nice and high, take some load off these guys, put the load up there. So we're still training our legs, we're still using our knees, but the pressure and force going through our knees is suddenly diverted over to the hips instead. We're still lifting, we're still strong, but the knees are happier. All right. Any ideas for changing a leg press? What's that? Perfect. Yep. This is all making my job sound like a bit of a cop-out, actually. You're all going to be really good EPs.
Positioning of leg presses, you go wider or closer depending on what's hurting.
Yep. That was going to be the one that I was going to mention as well. So really, to try and make the biomechanics of it as simple as possible here, if we got our legs pretty narrow and straight, narrow and centered, there tends to be a bit more load going through the knees than anywhere else. As Nicole just said, if we go a bit wider, twist the legs out a little bit, some of that load disappears from the knees, goes up to the hips instead. All right, and it's a little bit of trial and error of going, okay, let's try wide. Nah, no good. Let's try high. Oh, that's all right. Let's twist out. Oh, even better. There's your leg press for the day. Okay, yeah.
So consider like the angle of the leg press. So how you've got the 45-degree.
Yeah.
And then you've got the one more upright that usually can help.
100%. Yeah. And again, bit of trial and error. It does change how the forces go through the body, depending if it's the seated straight leg press, your 45, or not that many gyms have them anymore, but where you're actually laying on your back and your feet are up towards the ceiling. No one uses them these days, but they are around. changing the leg press. It might even be actually going, all right, well, leg press is too uncomfortable. Let's just try a sit to stand, up and down from a chair. So same muscle group. The last one, and I love hearing that you guys have a run club now, so I'm going to talk about it a bit.
Tomorrow, 7 a.m.
I could actually. I am planning. I've got a big run I'm planning on tomorrow, but I might actually come join for 5. Oh yeah, I plan on running a little further than 5 kilometers, so I might. Yeah.
Like Josh,
Josh
yeah.
does like 10k and then comes to run club and does 5k with us.
I have a marathon in 4 weeks, so I'm like at the peak of my training. So
They're in Christchurch one, is it?
no, Hobart. Yeah.
Josh's is in 4 weeks too.
Oh wow.
Christchurch.
Yep. Yeah. So mine's more of I think it's a 33k run tomorrow. So I'll come join for. I might actually come join for 5 and then duck off and. Yeah. And so here's a good example of how we modify running is going, oh, Alex's knees hurt. He can't run 30 plus K tomorrow. Let's slow it down and run 25K. Okay. That is obviously this end of the spectrum. The other end of the spectrum is going, okay, I really want to try running 5Ks, but gee, I just had a terrible sleep. My body's feeling a bit grumpy. Let's join in that 2.5K walk. Okay. Very appropriate, very, very, very fine, no matter what. Other alternatives, if you're running for your cardio and aerobic fitness, jump on the bike, jump on the spin bike over there with Joe. Assault bike, sorry, yep. Rowing machine, ski erg. Depending on what you're doing it for, we can modify it around that. All right. Best rule to follow during and after training, in my opinion, is your 0 to 10 pain scale. So everybody knows that. 0 is no pain, 10 is you go into hospital. And be honest with that, the amount of people I say 0 to 10, give me a number, and they go, oh, it's about a 9. I'm calling you an ambulance if it's a genuine 9. So be honest with yourself. 0 to 3 is green light. Hit the deck running, keep on going. You're probably, and I say probably because this is a very general presentation, you're probably okay. 0 to 3 out of 10 pain. Don't stress too much. You're probably okay. That's where we look at these modifications. A 4 or a 5 is your orange light. So this is two different ways I like to think about this here. What are you comfortable with? If you're doing your burpees and you're like, oh, that's a 4 out of 10. First thing I like to think about is what do you have for the rest of the day? Do you need to go to your granddaughter's 2nd birthday party and you're going to be on your feet picking kids up and playing? If you're a 4 or 5 out of 10 now, you're probably not going to enjoy yourself this afternoon at your granddaughter's birthday party. Okay. The other thing is if you know these patterns and how your body's responding, if you're a 4 or 5 out of 10, is it likely you're going to push to a 6 or 7 out of 10 later on from keeping you there now? So 4 or 5 is a bit more up to you. You're welcome to train through it, but the moment it gets to that 6, 7, 8, 9, 10, hit the brakes, red light. All right, we're more than likely doing more harm than good there. All right, so super easy way to follow it. Let's say Nicole's making you do lunges tomorrow morning. If you do a couple and you go, oh yeah, 2 out of 10, 2 out of 10, 3 out of 10, 6 out of 10, okay, hey Nicole, not good. And that's where we look at, okay, let's reduce the range of motion. Let's make you hold on to something so you can use your hands a little bit more. And if we can get that number back to a 3 out of 10, that's your lunge for the day, right? That's going to be the really easy way. Obviously, you guys will be all over this, but for everybody here as well, if you're exercising at home or going for a walk or doing a small home program, follow that one in your mind. Like, it might sound silly, but feel free to play around with the exercise and modify it. It's very, very unlikely you're going to actually cause bad damage unless you decide to go pick up a 100 kilo weight in the process. But most people are a bit smarter than that. The other few things to consider is pain shouldn't be getting worse after exercise. So you might go, oh yep, 3 out of 10 today, felt great. Lunchtime comes, afternoon comes, bedtime comes, and you go, oh goodness, that's a 7 out of 10. That 0 to 10 scale still applies after your session. Okay, so if you get 3 out of 10 in session, but 7 out of 10 that night or 7 out of 10 the next morning, it does unfortunately mean that session was still too high. So sometimes it's a bit of trial and error. Do the session, wake up the next day and go, ooh, not good. We pull the session back. We keep you at a 1 or 2 out of 10. And then that night, the next morning, if you're a 5, awesome. Okay. Does that make sense? Beautiful. Pain shouldn't be lasting for days on end as well. If you do your session 3 out of 10, but next day, day after day after day after, you're like, oh, pain's hanging around, that's where we should probably be getting it checked out as well. All right. So onto backs now. Backs are the trickiest things in the world. Unfortunately, I think everybody who put their hand up earlier for knees and backs, I reckon could also say backs for sure. I think everybody's had some sort of a bout of back pain. Back pain is the highest prevalence of all musculoskeletal health conditions in the world. Okay, it's ridiculously common. Number 1 cause of all disability worldwide. This stat I've got here, which I'll read out, might sound a bit strange, but I'll explain it afterwards. In 2020 alone, low back pain caused a worldwide collective of 69 million years lived with disability. So sounds a bit hectic. The way to interpret that is if you've got back pain and you can't live your normal life for a week, that's a week of disability, as to say. If 100 million people lose a week of their regular life to back pain, that's 100 million weeks of time lost. So in 2020 alone, there was 69 million years of life lost, as to say, alone just from back pain. Yeah, it's a very common one. And it's something that is completely different for everybody. So not that you can see these too well, but I want to pose the question and I want to get everybody's thoughts on what they think the most common cause of low back pain is. Yeah. Dysbulges. Yep, that's one thing people think. Sitting down, yeah?
Yeah, activity.
I'm so happy somebody said that. Actually, as an exercise physiologist, that makes me incredibly happy. Yeah, actually, sorry. As anybody in the health and fitness industry, yeah. I've got 4 options here. Everyone's pretty well, thinking along the right lines. And I want everybody to tell me what they think the most likely out of these 4 is. So the first one I've written is non-specific low back pain. So i.e. there's no clear structural reason our back hurts. Discogenic injury, so disc bulges, disc irritation, things like that. Osteoarthritis or muscle imbalances. What do we...
Yeah.
What's that? Muscle imbalance, disc... Muscle. Yep, cool. Everyone's thinking kind of along what I thought everybody would answer. And to confuse everybody even more, yep, the answer is actually non-specific low back pain. The most common back pain in the world has no good reason it exists. Yep. And that, as somebody in the health and fitness community and the medical community, I struggle with that thought every single day that I'm at work. And I think we all do. It's something that's really tricky.
Is that because you can't tell as a physician, or because people with the back pain can't tell you what they creates?
Bit of both, actually. So, we'll do a good assessment and go, all right, it sounds disky, it sounds nervy, it sounds arthritis-y, it sounds lack of physical activity. There was actually a really, really good study done in, I think it was 2010 or 15 odd years ago, where it was about 20 people from the age of 20 to 30, 20 people from the age of 30 to 40, 40 to 50, 60 to 70, blah, 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 and MRI'd every single person's low back. I'm generalizing this here again, in the 20 to 30 age category, on an MRI result, there are a good handful of people who went, oh, you have this happening, you have a disc bulge, you have a spondy, you have degeneration. The MRI says your back hurts. All the 20 to 30-year-olds went, no, it doesn't. Who cares what the MRI says? My back is completely fine. And they felt really good. You go up to the other end of the spectrum, the 80 to 90-year-olds, every single person had multiple pathologies of their low back on an MRI, but only about half of them went, oh, my back hurts. So what it means is, like we said, as a physician, we sometimes can't tell. A lot of the time we can't tell why, and that's where imaging comes involved. Imaging doesn't necessarily correlate with the clinical symptoms. And I've got a couple of examples of people I work with. There's one lady I'm seeing at the moment, her major disc bulge at L4, L5, all the fun neurological symptoms associated with it. She's having surgery next week or something to get that sorted. I then have a bloke who's probably about 10 years older than she is. He's about 40. He's got 3 clear disc bulges on his MRI. The bloke's jumping, squatting, deadlifting, feels incredible. Yeah. And that's why it's something that we all kind of struggle with, that back pain is non-specific and it's individual. It's not just what we see on the MRI, it's the psychological stuff, it's the social stuff, it's your previous experiences. And so if everybody's further confused, yeah, that sums up back pain. Yeah. Yeah. Just come in and confuse everybody with it. So yeah, it's non-specific low back pain. Generally speaking, what makes up non-specific low back pain is sedentary behavior, sitting too much, not doing enough exercise. The person who achieves, is anybody aware of the Australian Physical Activity Guidelines? No? Awesome. Most people aren't. Our guidelines kind of say we want to be chasing about 150 minutes of moderate intensity aerobic exercise per week. So that's about a 30-minute walk at a decent intensity 5 days a week, and then 2 days a week of resistance training, so your weightlifting. The people that hit those guidelines, the incidence of low back pain is very rare. The people that don't hit those guidelines, the incidence is a bit higher. So that doesn't make it really clear. It doesn't say why we're getting the back pain, but what it tells us is that people that live the healthy lifestyle and look after themselves don't get the pain as much as the next person. All right, that kind of sums up what non-specific low back pain is. And when somebody comes and sees me and goes, my back hurts here and here, it hurts when I do this, we'll assess and make sure there's nothing sinister going on. But a lot of the time it becomes exactly everything we've just discussed. Activity modification and what lifestyle factors are intervening here. A lot of these people, I ask them, how are you sleeping? And they go, oh, terrible. My kids keep me up all night. I've got sleep apnea, but I hate wearing my mask. It's not necessarily the back, it's all these other things that make the back hurt. Another way to think about it is if you've got a cold or the flu and it's like quite a bad cold, you ache. And it's generally in your low back that you ache. There's not necessarily anything going wrong with your back, it's just your body's response. All right. Again, here to confuse everybody.
Because to the guidelines, I am doing all that, and I sleep pretty well, I eat really well.
Yeah.
Lower back pain in my right, and it sits in my right side.
Yeah, and I don't want to harp on about that to try say.
But it's not a constant ache. It's just there.
Something's there, yeah.
Especially after I lift heavy.
Yep.
Yeah.
And yeah, it's one of the tricky ones where it's okay. Maybe nothing's going on. Maybe this is non-specific. What do we need to change with training? And it's really complex. Like if we went back to that very first slide where it had a billion different things that contribute to and affect pain, where's it come from? But then if we change one of them, it changes 4 others. And we change those 4, it changes 16 others. It's really tricky. I don't want to discount though, there are genuine pathologies. We've spoken about arthritis, disc things, everything like that. Not all back pain is non-specific. Like I said, it's the most common, but it's still pain. Let's still take it in consideration, treat it seriously. Okay, we still treat it all seriously. All right.
But like I said, it comes down to psychological.
Yeah.
So if there is something that has been happening in your life, like a lot of changes,
Yep.
that could be a big thing too. Yeah.
Yeah, that's it. And one sec, sorry. Oh, I was going to say, similar to like I said at the start, our brain's job is to go, I need to stay alive. And so we do something to our back, or we, going through heaps of changes at work and there's lots of family stresses going on. The brain may not have the capacity to go, all right, I'll look after this. You're busy burning energy thinking about other things and looking after other things. So that could be a contribution as well. So
I was just going to add, there's a lot of research at the moment around lower back non-specific pain for perimenopause and menopause.
Oh yeah, yeah, massive bodies of research around there, and not just low back as well, but low back's the most common, but shoulders, hips, knees, ankles, perimenopause. If you're around that age bracket and you start going, gee, I have no good reason my back hurts, that actually does trigger the conversation with your doctor of going, hey, I've got all these pains going on, could it be this? And then you can go run the bloods, get your hormones checked, and they'll go, yeah, it probably is. I actually had that exact example on Thursday at work. So I've been saying she's trying to get into running. Ankles hurt, cool, we sorted the ankles out. Back hurts, okay, we sorted that out. Ankles hurt again. Why do the ankles hurt again? Came in Thursday and she's like, guess what? Oh, what? She's like, perimenopause. And I went, oh, okay. All explained. So not necessarily all explained, but it is a massive contributor. So yeah, it's more than just tissue pathology is the gist there.
Sorry, Alan, a good question.
Yeah.
So in regards to stuff like this, are people better off going through like a checklist of things first and sort of like seeing where they're at with that, or would you recommend going and getting things checked first, like from a doctor or something, and then going from there, like which
Yeah.
like what order would you go check
For sure.
first, then
It's-
doctor or doctor, and then
It's a good question. Yeah, the answer unfortunately is it depends. I've got a little bit of a checklist again later on, but we'll cover a bit of it now. With back pain, your red flags are neurological impairment. So if you've got change of sensation in your legs, altered sensation, numbness, pins and needles, lack of power, and lack of power is probably one of the scarier ones. If you stand up from your chair one day and your leg gives out, maybe don't see, oh, I'll see what training does. Get that one checked out. It sounds a bit silly. A lot of it comes down to common sense of if you wake up and go, oh, I really am not comfortable with this, we get it checked out. Whereas if you go, oh, my back's on and off, I'm not having a good day with it, but I can tolerate it, you're probably okay. But neurological changes are the big ones. So sensation and power generation. Big, and we'll touch on that a bit more. The other thing is how much are you happy to tolerate the pain? If you're like, yeah, I can go to work, I can go for my walk this afternoon, it's probably not too urgent, not to discount it, but probably not super urgent. Versus if you go, holy moly, I have to take the day off work, I'm in that much pain, you probably need it looked at. All right. So another yell out if you've heard anything or answers or anything like that. But has anybody heard of any exercises in particular that are bad for our backs? Yeah, and I already had pre-prepared a thing for everyone to say deadlifts.
Heavyweight back squats. That one scares me.
That one scares. Yep. Yeah, they're two of the big ones.
I actually hurt my back doing this. I was just too heavy, and that was my fault. Just
Yeah.
pushing it.
Yep. It's we.
Just yeah.
Thank you. Well done. Well done. Yeah, they're the two big culprits that everybody says, and you will read about it online all the time. You see it all over Instagram. There's a bloke in his scrubs with his orthopedic surgeon cap on going, never deadlift, it makes my job too hard, sort of thing. Going back to what I said earlier with the knee stuff, my take and my opinion is there's no such thing as a bad exercise. It's how we load it or modify it or complete it. So like we just said, was it too heavy? Was our body not ready to handle it? Was our technique poor? We'll go through a little bit of that with deadlifts again shortly, but yeah, for me, I love deadlifts. They're one of my favorite exercises, and counterintuitively, one of my favorite back rehab exercises too, if done properly. And everybody thinks deadlift and goes, oh, massive bar on the ground, heaps of weights on the side, it sounds pretty scary. When I use it as a rehab exercise, it purely is just a hip hinge of don't hold any weights, just run your hands down your thighs and down your shins and practicing that hip hinge motion that is a deadlift. Because a lot of the time with back pain, and again, I'm generalizing, is we have trouble doing that movement. And so we go to pick up a weight and go, oh, yuck, not good. How we build the capacity and how we get our body to adapt is we start just with body weight. It's the same as when you first start squatting. You do your body weight squats, you then grab a dumbbell or a kettlebell, you then put the bar on your back and then add weight. Okay.
If you don't do that rehab, you're going to pick up something heavy somewhere else in your life. And
Yep.
it'll be worse than if you had done that variation of that deadlift.
Yeah, really good point. And it's a conversation I have every week at work of, oh, no, I can't do that. That's too much for me. That 5 kilos is too heavy. Oh, okay, but how heavy is your 6-month-old grandson? Oh, he's just hit 12 kilos. However much a 6-month-old weighs, I don't know. And I'm like, oh, do you enjoy picking them up? Yeah, I love it. And that's one way of going, yeah, day-to-day life, we actually do need to be lifting these weights. You go to the shops and buy 2 bottles of milk and a couple of loaves of bread, you're walking out with 8 kilos worth of groceries. So we do need this capacity. Yeah. Oh, 3 litre bottles of milk. And a couple of treats I don't tell my partner about. Actually, so yeah, with backs, before we move on to the next part, does anybody have questions? Back pain is incredibly confusing and there's so much going on. But yeah, any questions?
I feel like you've covered it a fair bit, but I also hear this a lot around the gym and getting myself to it's kind of a belief I guess I have that
Yeah.
if like I try to find the difference between I need to train today because my body needs it, it's good for me, and if I push myself too hard, then I'm in pain. Like trying to find that difference between
Yeah.
what's gonna hurt me more and when I need to listen to my body and rest.
Yep. This is a really hard one.
I feel like you mostly answered it.
Yeah.
Capacity, the red lights, I'm going to use that as well.
Yeah.
Anything else you have for who push it too hard?
Yeah, it's a good question because I'm in the same boat. If I have a bad sleep tonight, I'm still going to try to do my 30+ kilometre run tomorrow. May not be the best idea. And so yeah, mentally, I love health and fitness. I'm going to be doing stuff. Where do we draw that line? It can be a little bit of trial and error with this. And I know that sounds like a little bit of a cop-out saying trial and error, but take things slow. If you're like, I love being in the gym, I want to go to the gym today, I want to do my session, slow your warm-up down. All right, we're all going to warm up in some capacity. Maybe you do a longer warm-up. You spend a few extra minutes on the bike, you spend a little bit more time stretching. If deadlifts are on for the day and you want a deadlift, but your back's a little bit grumpy, it might just be going through a dozen of those body weight hip hinges that I spoke about. And then if your goal is to get to 50 kilos for the morning, you might start with your 10 kilo dumbbell, 20 kilo bar, 30 kilo bar. Cool, I feel good. Let's try 50. Or 5 of these felt a bit grumpy. Maybe I settle at 3 for the day. And then if you implement the traffic light analogy, then that's when it's like, okay, I might have gone too far. So it's, again, it very much depends. And I like trial and error. If you are comfortable in going, here's my traffic light analogy, here's my modifications. Thankfully, you guys have got a really good team of personal trainers to help you out with that. All right. Yeah.
Sorry, I was just going to add in because I know that is like a big thing that we run into.
Yeah.
I would just like remind yourselves too, like when you do a workout, it's not like you have to do a workout where you're hitting PBs every single session as well. Like,
Yeah.
there's like, I'm still moving. It might actually make you feel a little bit better if you don't go full, after having a shitty night's sleep, you're probably in a bad mood, all this stuff. So taking it easy might even help you mentally, but sometimes just starting a workout, you'll probably sort of know if it's a good idea or not. But in saying that too, like with the coaches that you guys have, if there's like an exercise that you do have, like Alex was saying, like the deadlift, there's so many other exercises that work the exact same muscle group just because it's in your program. Like I take things out of my program some days. Like you don't have to follow the program. Or you could even say, I've got a leg day, I am in a lot of pain, I'll just do like, a walk, or like I'll just do an upper body workout or a core workout or something. So
that is an excellent point. If you look at your professional sports athletes, let's say in the NRL, one of the boys pulls his hammy Friday night. His training session Monday, he won't join in with the team. He'll be on the bike, he'll be with the physio doing rehab. He's still training, he's still being fit. He's just doing his own version. The other really good point there, I think, as well, is if we go back to that biopsychosocial approach, is the social component. This could be, and probably is, your social outlet with exercise and physical activity. Even if you come in and chat to the team and go, gee, I feel crap today, the knees are killing me. I'm gonna try this, oh, it didn't work out. I don't know what your guys' policies are, but I imagine you can probably just come hang out for the morning and be part of the team. Or instead of being able to do the 5K run tomorrow, join in the 2.5K walk and hang out with your friends. Go grab a coffee. Yeah. Yeah. Yeah, actually, yeah, no, it's a really good point coming back to modify. And modify doesn't necessarily mean, all right, we just dropped the weight. That's a great modification. But modification could be, all right, well, I'm just going to hang out for the day and just do a brisk walk on the treadmill or something like that. Yep, that's it. And your capacity changes every day. Yeah.
The other thing is too, like, I've got nipple knees, I've got played pretty for national misspent youth.
Yeah.
Trying to get to what the old menopause and the osteoarthritis and all the other crap that comes in as you get older.
Yeah.
You don't realise the impacts of what you're doing at 15, 20 is going
Yeah.
to happen on your body at 50, 60.
Yeah, and that's a really hard consideration because I'm
These guys.
yeah, I'm only in my late 20s and I sit here and go, "Oh, gee, no, this is fun, this is awesome. Who cares about 30 years time? Yeah. Every netballer I work with, every time they tell me what their week looks like, I'm like, how? When do you have the time for this? But massively good point as well.
Can I just say though, it's really beneficial to talk to the team. I had to spend about 15 minutes brainstorming with Bree one morning.
Yep.
Why my knee was killing me. I was about ready not to come to a leg day ever again.
Oh, yeah.
We worked out it was the balance fault, so any instability. So you've talked about
Yeah.
reducing weights. But if you have knee issues, you have to watch out for any instability because if you do so
Yeah.
we worked out that it was that and I don't use that, I've been fine.
You're good. Yeah. This is where it gets, person by person, and it gets quite tricky. Obviously, you look at yourself with ACL, meniscus, everything going on there. Stability and perturbations and proprioception is a massive component. Things like that we have to consider. Obviously, haven't delved too much into today, but the load and capacity still applies there. And another example of it, bloke I'm working with right now, he's a firefighter. Ruptured his PCL, so it's a ligament in his knee. It sort of does the opposite of your ACL. He ruptured it at work. He's not getting it surgically repaired. He's in his early 50s. He's like, I don't really care. So it was just, all right, let's get the strength, let's get you moving. Did really well. And then we started getting him into his like plyometric training, getting him like jumping, hopping, things like that. The moment we entered hopping, bang, knee was swollen and blown up. Okay. Great strength, great, deadlifting 80 kilos, squatting 100 kilos. This man's in his early 50s. He's doing incredible. Doesn't have one of the ligaments in his knees. We introduced hopping, kaboom, gone. Load versus capacity. Okay, his body can tolerate this. From a plyometric perspective, hopping's here. So we went to bouncy calf raises, I call them, where he was just doing these. And his knee could tolerate that. We built his load, his body adapted. He's now hopping. He'll be back at work. Oh, touch wood, in 2 weeks' time, if everything goes well. So it's another really good point. The instability, the balance components. When I'm talking training, I've mentioned running and lifting a lot. It's not just that. Balance instability is massive as well. The load and capacity still applies, but we've got to think about it quite differently. So another really good point. Anyway,
Obviously, if it's swollen, you suppose if you want to like heat, is there any way specifically say
very controversial question here. Everyone's probably seen recently, it used to be, RICE was the acronym. Yeah, rest, ice, compression, elevation. And then it changed to POLICE, which was protect something,
So much.
Yeah, and then it became peace, and then it became peace and love. I actually don't know what these stand for, but it's too much, yeah. Good question. Generally speaking, and again, this, like I said, this is very controversial. Swelling and inflammation is your body trying to heal itself, and ice and cooling can slow that process down. It stops the swelling, but the swelling is all these good things going to the joint. But also, with swelling and discomfort, the more uncomfortable we get, the more everything's aggravated. We do need to settle that down with things like ice. So it's a really, really hard one. So if ice feels good, use ice, basically. I'm not saying don't use it. In terms of the heat component, my advice and opinion on this is if the injury is acute, if you roll your ankle going down the stairs this afternoon, please don't. But if you do, touch wood. Don't use heat because heat's going to be progressing things. Actually, the best example is like contact sport. Somebody cops a knee to the side of the thigh and it's really, it's going to get bruised. If they go home and jump in a hot bath, blood vessels dilate, more blood rushes to the point of impact, the bruising suddenly significantly worse. Okay, and then they're back to sport even slower. So acutely, stick with ice. Once it's past that acute stage, and again, it depends injury by injury, but generally speaking, a week to a couple of weeks, that's when it's nearly personal preference, actually. In terms of pain relief and comfort, if you prefer ice, go with ice. If you prefer heat, go with heat. Okay. Again, it depends. I know that's a very not fun answer, but yeah, acutely, ice or nothing. After a few weeks, whatever you prefer, pretty well.
So straight after, don't put it on.
Don't put heat on, yeah. So there was actually an example, not that I've seen, but one of my colleagues has told me about of a sprained ankle and like a grade 1 ligament tear in the ankle. So grade 1 is like torn a few fibers, but nothing major. It just needs a couple of weeks to heal. This kid went home, jumped in a hot bath and went, I feel better. Tomorrow morning, bang, ankle's this big, sort of thing. Versus had he done nothing or iced it, yeah, it would have still swelled up, but it's probably only here rather than here. So yeah, if you do something, don't throw heat on it straight away. Okay.
What's also mean for lower back pain?
Oh.
Sleeping would be helpful if that's what you want.
Yeah, 100% actually. Low backs, most people tend to respond better to heat. Same principle. If you are in the gym this morning and you do your 3 minutes of burpees and you go, oh goodness, I wouldn't use heat then. But if you get home this afternoon and go, gee, Alex harped on for ages, my back's so sore from sitting down, throw heat on. Yeah, again, ice or heat, whatever you're more comfortable with. I've got a few grumpy neck issues going on with myself at the moment. I love heat, works the best for me. Okay. Does that make more sense or answer your question? Yeah, cool. Next up, what I wanted to cover is common gym myths. And this is something that I think from a activity modification perspective, I think is worth covering. I'm nearly at the end, I promise. I want to get everyone's thoughts. True or false, knees shouldn't go over your toes when we squat. Who thinks that's true? Perfect. This is a... Thank you. Yep.
Especially in a heel elevated squat too. I don't understand how that could even happen.
Yeah, awesome. You guys are all over this one. This one irritates the hell out of me. People come in and go, oh, but my doctor said my knees shouldn't go forward over my toes when I squat or bend down. My response is exactly what we said here. How can they not? Okay. If we have terrible mobility in our ankles, so when we bend forward at the ankles, that's how our knees get forward over our toes. If we can't bend our ankles, suddenly our squat, instead of going straight down, becomes this to squat. Our knees have to go forward. Okay, so I'm glad no one thinks that. I get it at least once a week. So awesome, great start.
Still so strongly believe.
Yeah, yeah.
I used to believe it.
It's so common.
It was just so common. That's how it was.
I think the origin of it was a surgeon back in the 70s or 80s went, oh, too much shear forces on the knee, don't do it. But, you know, I didn't take into consideration how people actually stand up from a chair.
Yeah.
Like,
Yeah, that's right.
you know, again, activity modification, we're not going to put 300 kilos on your shoulders and get your knees over your toes. You're going to hurt yourself. Next up, if your back hurts, you shouldn't bend it.
False.
Good. Everyone's been listening this morning. Our backs are made to bend. Most people have 26 vertebrae. Each of them have about 3 degrees of movement in every direction. They are made to bend. Okay. Again, activity modification. If your back hurts when we bend this far, we stop and bend that far. Okay. It might sound silly, but one of my early stage rehab exercises is going, all right, well, you hate being down here. We need to expose you to these movements. We're just going to start with a couple of rocking back and forths here. Okay. Oh, I love this next one. Lifting with a rounded spine is bad. Yes, no, false. Any other thoughts? Cool.
Do you mean upper back slightly? A little bit?
On your neck.
Or do you mean
Yeah.
lower back?
All of the above.
Yeah. That's fine.
Yeah, I'm saying it depends. If it's upper back, I'm saying it's allowed slightly. If I'm
Yeah.
saying lower back,
Also depends when you lift as well.
yeah.
Yeah. So again, if everyone's getting confused, good. it depends is the right answer. All of these come back to load versus capacity. If you go pick up a 1 kilo dumbbell with a rounded spine and you look like a camel, you're going to be fine. All right. You're going to pick up your grandson or your cat or your dog. You're not going to bend over to pick up your dog like this. Our back bends. It is meant to bend. You're not going to pick up the 200 kilo barbell that Joe's been using for his deadlifts though, with a rounded spine. You will hurt your back. Okay. It comes back to load versus capacity. So deadlifts is the most common example again. Technique wise, everybody harps on about keep your back straight. And yes, for the best point of a deadlift of getting your hip and knee strength up, we want that. Depending on your load and capacity though, a small bend won't break your back. Okay. I say won't, shouldn't. It depends on load and capacity. The example I use here is gymnasts. If you ever watch the Olympics and watch the gymnasts, those guys are jumping off 10-foot poles, doing 10 flips in the air and landing. And most of the time when they land, they're either back here like this or a little bit over. If they weigh 80 kilos and they jump from a 10-meter height, for example, that's about 1,000 kilos of force going through their spine. They train that, okay? They have the capacity to tolerate that. We do not. Okay, so the general rule is, yeah, try to keep it all straight and neutral, but capacity is a big thing again, okay?
What about when you're doing your press, like the arch in your back?
Yeah, good question. Look, load and capacity come into it. My approach with an overhead press though is, you guys have probably all heard the saying, you can't shoot a cannon out of a canoe. If you load a cannon in a canoe and try to shoot it, the canoe is going to fly back 100 meters. We need the stability and the support. If we're arching around like this, we can't generate as much power because we're going to fall back into the ground. Whereas if everything's nice and neutral, we've got all this force behind us to create an equal force to push up. So from an injury perspective, try not to. From a technique and lifting perspective, you'll lift more weight and you'll lift it better if you keep it straight. Yeah.
Because I have like a really great example of this.
Yeah.
This week, I couldn't bench press the exact same as what I was doing last week because I tried to have an arch in my back.
Yep.
And I couldn't lift as much.
And that's the cannon out of the canoe analogy. You load
I
you.
didn't have that arch in my back when I was doing this. I was just trying a different technique.
Yep. You know.
I couldn't lift as heavy.
No.
There you go.
That's it. Yeah. Did you have something? Though? You're right.
Just question with this as well, like, would you say sometimes when people are doing like this a lot and stuff like that, it's people not also engaging their core properly? Like, have you seen when people try and engage their core, they're like, they do this or something. Like, do you get what I mean? Like, would you say, like, core strength would tie in a little bit with some of like the lower back?
Definitely. There's
as well?
for the overhead press, there's two common culprits, and core strength is one. If we think about core is everything around here. Everybody thinks core is just your abs. It's everything. Core strength is one. If we think about our abs, their job, they go from your hips to your ribs. If we think about a rope heading up there, we pull the rope, we're up straighter, okay? But then in saying that as well, your glutes are part of your core. If our glutes are engaged, our hips will be a little further tucked under. We have these engaged, we stay nice and neutral. The other culprit is shoulder range of motion. If we're not capable of getting our arms directly over our head and we're stuck here, the compensation is to go, instead of doing that, we go like that. So yeah. Bang on. Next one, I hope everyone can answer this one now. Pain means damage and therefore we stop exercising. Good, perfect. Bit of a different one. Exercise helps with sleep.
Yes.
Good, perfect. And last one, which we've already touched on actually, running is bad for your knees. Good. Again, load and capacity. All right. So again, this is a bit of a summary of everything we've said. What do we need to be doing in the gym while we're in a bit of pain and discomfort? Modify, don't remove. All right. I don't know about your guys' training, but one of the big things is what we call the FIT principle. FIT standing for frequency, intensity, time, and type. Those are things we can modify. If we squat 3 times a week, maybe we change the frequency to twice a week. The intensity, we drop from 50 kilos to 30 kilos. The time, is that time under load? Is that time between sets? Let's drop it back and modify it. Type of exercise as well. Maybe we go, squats are no good. This closed chain, feet on the ground, bar on the back hurts. Let's change the type to a leg press. Okay, so they're your modifications that you can do. Modify the exercise selection. Progress gradually. If you're sore and you modify things to then bump it back up, you don't go, oh, my back feels good, let's go straight back to 100 kilos. No, gradually build it up there. Building strength. This is, everyone's healthier when they're stronger. So it's a pretty general summary there. And communicate. Like we've already said, chat to these guys when you come in for your session. Tell them what you're feeling. If you've got patterns that you can identify of, oh, when I do this, it aggravates it, let them know, because they can then change the type of exercise. You know, a single leg weight bearing plus knee flexion creates pain in my knee. All right, let's get double leg weight bearing and less flexion. Awesome, feels good. Okay. And then as well, communicate with yourself, be honest. Again, use that pain scale. Don't go, I really need to exercise today. It's great for my body. And like, yes, it is. But if you're at that 6 out of 10, like, please be honest with yourself. All right. When to see a professional, and I think everybody's probably got the hang of this now, but with the knees, one of the biggest ones is a locking, catching, or giving way sensation. ACLs and meniscus, you're going to be super familiar with this. If you've got a knee injury and you're walking along and you're like, oh, it's caught, it's stuck, get it checked out, okay? We've already mentioned loss of power and strength, pain worsening with rest. If you take some time off but it keeps getting worse, get it checked out. Non-mechanical pain, this one sounds a bit strange, but basically, you know, if we've got a sore neck or back and it wakes us up in the middle of the night, you go, oh, that sucks. You roll over, you change position, it feels better, you can get back to sleep. If we roll over, change position, and just nothing is working for us, we get that checked out. Okay, so that's what non-mechanical means. Pain that persists for a few weeks, or you can no longer tolerate. This is again where you use a bit of your common sense and you go, no, I'm just really not happy with this. Like, you're allowed to get it checked out. That's why the health profession exists. You know, we don't want to be in pain. Nobody wants pain. You're allowed to get it checked out. And fear of movement is the last one. This might sound strange, but if you've had a traumatic injury, trying to get back to the exercise that did it or trying to get back into the gym is really quite scary. Okay, so if you've hurt yourself and your knee's killing you and you look at a set of stairs and you're like, not comfortable, probably worth getting checked out once that fear sets in. Low back's very, very similar. We already mentioned loss of power and neurological changes. One caveat with this is, and this gets a little bit medical, but loss or change of sensational function in your saddle region. Saddle region is, think about all your body parts that would sit on a saddle if you're riding a horse. If you wake up one morning and you can't feel down there, or you've woken up and you've wet the bed, don't just think, oh, I'll see what happens with it. That's a medical emergency. I've never seen it in 7 years of being an EP. But I don't want people to go, oh, altered sensation, I should just get it checked out. If you've wet yourself and you don't have any incontinence issues, get it looked at. Okay. Super rare. Hopefully no one ever sees it or experiences it. Non-mechanical pain again, pain worsening, pain that persists for a few weeks, and fear of movement. So should I get it checked out? Should I exercise? There's a few key red flags of I've lost power, my body's clicking, catching, grinding, neurological symptoms. There you go, get it checked out. Who checks it? Oh, sorry, yeah?
Sorry, I'm just gonna ask, what's the difference between like when you should go to the physio versus exercise? Like, set at the same time, one for the other?
Yeah, that's actually my next slide.
Oh, okay.
Yeah. So a question I get at least once a day at work, and every time I do one of these things is, what's an EP compared to a physio? How are you guys different? So lots of similarities is how I tend to describe it. We both have 4 or 5 year uni degrees, depending on the process. The main way I describe it is, as EPs, we tend to work more with chronic health conditions. Physios are more acute. If you roll your ankle on the footy field and your ankle blows up, you can come see me, but the physios will do a better job. Versus if you have diabetes or a cardiac condition or something along those lines, you can go see a physio, but they'll send you to me anyway. Okay, so lots of similarities there. So in terms of pain, if we do your 3 minutes of burpees and you go, oh, geez, that's not good, it's acute, physio. Okay, versus if you've got this little niggly back pain that's been hanging around for months and months and months and months, there's not really a wrong option there. If you come see me and I'm like, oh, there's something more sinister going on, I'll send you off to the physio. If you go see the physio and they're like, oh, nothing scary is happening, like, let's look at strength and lifestyle, they'll send you to me anyway. If you're not sure, the answer is always your GP. Okay, first point of call is GP. But again, you can come see us, we'll send you in the right direction either way.
Sorry, I don't know if this question is something you will be able to answer, but
Go on.
do you have any advice or like knowledge behind physios and chiropractors? Do you have any?
Uh,
Can I just say my interpretation makes you feel better, so you don't have to maybe.
I'm going to give a very diplomatic response anyway, but go on.
Sure, from my response, this is just when clients come to me. And like, this is absolutely no judgment. This is just from stuff I've studied and heard other physios say. And yeah, would you say chiropractors would be more of a, like, I know they do help some people in regards to some things. From my understanding, though, from the amount of times that people go to a chiropractor, it seems like a more of a short-term relief sort of situation. Whereas, would you say with physios, it's more of a approach where you're trying to
Yeah.
fix the problem, so it's like fixed
Not just putting
long
it
term?
down.
Yeah.
Does that make sense?
And-
I could be very wrong.
No, that's the common trend and thing that you see. And it's a question I get a lot as well. My take, and I've worked forever with physios in the same office as physios, so I know them really well, know what they do really well. I've never worked with chiros or alongside chiros, so I can't make as much comment with them. My opinion, and this for the first few years of my career, I had a very similar opinion. Only as of late have I become a bit more, you know what, whatever helps, helps. If you go to the chiro and you have a good chiro and you feel great from what they do with you, brilliant. If they help you get out of pain and help you function, awesome. Same with every other health profession. Like nutrition's a big one. We talk about accredited practicing dietitians versus nutritionists, and all my dietetics mates will blow up at the mention of the term nutritionist. If they help, is my big view. Yeah, so if you've got a chiro that you trust and you like, or an osteopath or whichever health profession, go see them. I'm like, absolutely do. I'm only talking about EP and physio because these are probably the most common these days and it's the ones I know about. Yeah, so sorry, not too much information in my answer, but
That's okay. That's fine.
whatever helps you function and gets you out of pain, I will be in full support of all the time. All right. But yeah, if you're not sure, you know, do I see an EP? Do I see a physio? I've never seen one before. Wherever you want to go, and you know, Up and Active is a pretty good place. Give the team a call and just ask the admin team. We try and give them as much training as we can. Of if the person says they've got this going on, they should be able to point you in the right direction. If they're not sure, they send us an email and we get back to them and they'll call you back. So, but again, first point of call if you don't know, GP. Okay. So take home messages from today. Pain does not necessarily mean damage. Yes, it does a lot of the time, but it's not always just damage. Movement is usually helpful and load management is key. Okay. Any last minute second questions? Oh yeah, we'll start here.
Just what are your thoughts on like those things, for example, there's that bone shaped elastic strip you can put up on your knee and everything.
Oh.
Knee pads.
Yep. Hard one to answer because there's so many types and reasons that they're used. Simplest way to answer it, and it's probably not the best answer for you, sorry, but if it helps, similar to the chiro one, if it helps, good. If you're, particularly where your knee's been, you've probably got some feelings of instability and giving way. Knee braces, knee guards, restore that feeling of instability. Okay, so, and it might help you get through exercises, it might get you through day-to-day life. If you're at that 4 to 5 out of 10 on the traffic light analogy, maybe that knee brace takes you back to a 3. So all for it. The only caveat is when people get dependent on them. And sometimes there's circumstances where, or injuries or conditions that, yeah, we're just going to use them forever, and that's completely fine. But if we have an acute injury and we put a knee brace on and it doesn't get taken off, that's what our body gets used to. So all for it. It's just a bit of trial and error again. Sorry, not the most specific response, but I'm a big fan. Anyway.
When I'm sitting, there's a lot of clicking going on when I stand up.
Yep.
Is that a problem or is that?
Oh, I should have put this one in my myths.
Yeah.
Actually, yeah.
Not necessarily pain, but something it's just.
Clicking.
I
Yeah.
don't.
Clicking, grinding, crunching, the fancy term is crepitus. Any of that in any joint in the body, as long as it's not associated with pain, swelling, or adverse reactions, don't stress. Our body is full of fluids and gas. Knees have ligaments and tendons that sit so ridiculously close to each other. So for me, you can probably hear it. My knees, I I haven't had knee pain or knee issues in 15 years. The general rule is as long as there's no adverse effects, yeah, it's fine. In saying that, if I do that, sorry, and I go, ow, problem. Okay, so 99 out of 100 times, don't stress. While it doesn't sound great or feel great, as long as there's no negative connotations with it.
Just wearing like guards and I feel better exercising. I don't have any major pain.
Yeah, it's ridiculously common, I reckon. Yeah, I reckon.
Much heavier than you, much older, twice your age.
Yeah.
So I'm very concerned about the next 30 years.
If you, yeah, no, and good that you're thinking ahead. It's like I said, don't stress if there's nothing associated with the clicking. I reckon nearly everybody in this room will have a joint that when they do this, their shoulder does that or something. Don't stress. Okay, easier said than done.
With my like lower back pain,
Mm.
when would you like recommend on getting it looked at if it doesn't like the time frame?
Yeah, good question. Depends on what you want out of it. And that might sound a little bit of a cop-out response. Thanks, guys. If you're like, you know what, Toowoomba Marathon Festival's coming up, I want to smash that 10K, but my back's getting in the way, get it looked at. But if you're quite happy to go, yeah, I'm keeping fit, coming in with the team here, I'm enjoying myself.
Well, I'm doing a Spartan in May, so
Yeah.
I need my back at
My advice would be,
full capacity.
if you think your back's going to get in the way of training and getting you ready, ready for that,
Yeah.
I'd get it looked at. But if you think it's something you can tolerate and manage, and if you're happy to tolerate it,
Yeah.
I wouldn't stress. But again,
Yeah, like I said, it's not doing anything. It's not doing
Yeah.
anything major. It's not I can still do everyday things in my day.
Yeah.
I can still train.
yeah,
It's there.
yeah.
Yeah.
One major thing to remember as well is it's never going to hurt to have somebody's opinion or advice, have it looked at. Like, let's say you came and saw me. Worst case scenario, I might say, look, I don't think there's anything sinister going on. These are other management strategies you can implement. See how you go. And I think getting that reassurance of, okay, I don't need to be stressed
Yeah.
is still worthwhile.
Yeah.
So if you're not certain, there's no harm. The only thing it might hurt is your back pocket. If you're not certain, there's no other harm in getting it checked out though. So that's all right. Any other last second questions or anything?